Welcome to day 2 of the workshop. Our first session today is a symposium on the clinician's point of view, experiences of using AI algorithms in the clinic. The coordinators for this session are Professor Pramod Garg, who is online. Dr. Sheela sends her apologies, and the third coordinator is Dr. Yashdeep Gupta. I request Dr. Yashdeep Gupta to come on the stage. Dr. Yashdeep Gupta is additional professor in the Department of Endocrinology and Metabolism at All India Institute of Medical Sciences, AIIMS, New Delhi. His team works on diabetes and pregnancy. He has been honored with several awards, such as the Novartis Young Investigator Award, Anil Seth Youngest Investigator Award, and the AIIMS Excellence in Research Award for Clinical Category. Over to you, Professor Garg.
Good morning, ladies and gentlemen. I'd like to once again thank the organizers for giving this opportunity, a very important session where what clinicians feel and what they expect in terms of AI in healthcare is going to be discussed. And thank you very much, Yashdeep, for joining in person as the moderator there. So I will request the first speaker, Professor Ashok Khurana, to give his talk. Professor Khurana is an ace radiologist who has been working for a long time in developing new algorithms, particularly in the area of fetal medicine. And he's someone that everybody looks forward to when it comes to fetal ultrasound at various stages, especially in complex pregnancies. And he's a much sought after radiologist, not only by patients, but also academicians, and I'm very happy that there is a long-term collaboration going on with him and the MCH team at THSTI. So without further ado, I would request Professor Khurana to deliver his talk.
Thank you very much for that very kind introduction, and a good morning to everyone. It's a pleasure to be on the platform here. I'm going to share with you my experience of using artificial intelligence in the clinic. And as soon as I see my feed on the screen, we shall start off. It's wonderful to be a part of this team. When I first came onto this team, I didn't know where we were headed. But I knew that the most important thing would be to make sure that we have robust data. So we slogged, and I know the number of visits that Nitya made over to the clinic, and we spent absolutely hopeless moments wondering what's going to go on. Then we went into the training phase, and today we actually have all of that that is going on a commercial machine. And I think that's really the fastest translation that we've ever come across. And so I will take you through my experience of using artificial intelligence on a daily basis. And it's really wonderful how we've been able to take some of the Garbini data through the Calipers program and so on. And we know that all this is changing the world. We know for sure because it's not only just people who've mentioned this from industry, such as the Future Health Index, which came out from Philips a few weeks ago, but the fact that healthcare hits reset and we have changed priorities. And at a global level, we do realize that we have a change in people who are working in radiology. And that change has been admitted by over 31% of radiologists. And we do realize that this has found space not only within the profession, but the fact that we have had evidence published in the Lancet and in the BMJ. We also realize if you look at Google that this changes every single night. And I like to catch up on what's happening last night for the talk this morning, because we have all these smart children at the back who are always one step ahead of you. So I want to make sure I haven't missed out on anything last night. And we do realize that we actually had 198 crore articles on AI in healthcare. And if I narrow that down first to women's healthcare and then clinical uses and finally OBGYN ultrasound, I was still left with 345,000, which I think is a delicious amount of stuff. It's not that I use all those 345,000, but the fact that a lot of it is something you can actually use every day. And so I will take you through um, the recreation of really God and Adam and show how it has changed completely the way we practice on a daily basis. So it's going to be a list of AI applications in current daily practice. And I will also highlight the difference between what we call semi-automation, which is the minimum amount of intelligence, not so much even artificial. There is automation, and then the real intelligence starts creeping in when there's advanced automation. And then, of course, the honest to goodness, hardcore, purist artificial intelligence. And of course, I'll highlight why AI is a tool and a boon and not a threat. But I don't think we're under threat from that sort of a thing. Anybody who thinks that AI is not a boon or a tool is outmoded, out-fashioned, so should be defenestrated, which you know what that means, thrown out of the window. So that's extremely important to understand, because there's no way we can get left behind. We owe it to our patients that we do not get left behind. So here we have this case. She comes in this time at 35 weeks with a previous completely uneventful pregnancy. She's young, she's only 28 years old. And she says, this baby does not feel the same as she was feeling yesterday. So we examine her and we find that she has a heart, the fetal heart rate is 230 to 238 beats per minute. And you know, our upper limit is only 180. So we label it as a fetal supraventricular tachycardia. And on the ultrasound, we realize that there's a short VA interval. So the choices I have here is to give the mother flecainide and wait for this to settle, but the baby might die. I have a choice of giving her betamethasone and getting the fetal lungs ready because she's only 35 weeks, or I can deliver immediately if that's what she wants and doesn't want to take any chances. But I run the risk of prematurity, and this is a very real risk, because if she dies because the baby dies because of immature fetal lungs, then it's a failed exercise. So what do I do? In the olden days, I had to do an amniocentesis, wait for the results. But today, I run a non-invasive, image-based test for fetal lung maturity, which is based on artificial intelligence. That tells me straightforward that this baby now has decent lungs. I go ahead and advise a cesarean section. The baby's alive, healthy, and kicking. So what's the basis of all this? Well, typically, what we've realized that up to 39 weeks, and all the way up to 39 weeks, we know that babies may have immature lungs, and we need to make sure. And we really have to decide whether the risk of the disease is more or the risk of prematurity is more. And what we've been doing so far was to stick a needle into the maternal uterus, take out amniotic fluid, send it off to the lab, and then you never know when the results are coming in, because if it's Saturday night, maybe nobody's there. If it's 14th August and we have Independence Day next day, we might be stuck and so on, or we just might not have that in our facility. And then, of course, we have a risk of the amniocentesis itself initiating delivery. So we were stuck between the devil and the deep blue sea, but we realized that with the help of artificial intelligence, I now have a test which has a super sensitivity equal to that of the lamellar body, which is what I look for in amniotic fluid, that it has a great specificity, better than everything else, that the positive predictive value is also good, and it matches the negative predictive value. How does this work? Well, we tried all kinds of stupid things initially, and then moved on to this wonderful work by Monse Palacio at the Fetal Medicine Clinic in Barcelona. And by 2017, we had every famous name in the world in fetal medicine having tried this out. And this wonderful article coming out on the ajog.org, which told us that if I take an image of my cardiac 4-chamber view, which is a standard. Oh, my slide stopped moving. Why did my slide stop moving? Let me see. My slides are not moving here. They're moving on my laptop. No, we missed one. Never mind. So what we do is we take a nice, wonderful 4-chamber view, which is my standard view. And then it's to be taken under your standard cardiac preset without any effort, except as usual, the spine should be either here at the 3 o'clock position or at the 9 o'clock position. I then save this image as a DICOM on my machine. I upload it on the internet, which is the specific server for this particular function. I used to have to actually highlight the lung, which I no longer have to do. I just now have to load this just as it is, submit it, and within 5 to 10 minutes, I get an answer at any time of the day or night. The server is sitting in Spain, but it works beautifully. And this is the kind of report I get because that information is put into a texture extractor, nice old-fashioned texture extractor. It's old-fashioned, so it makes the test cheap. And the algorithm is run, which is a simple old-fashioned machine learning approach, and it tells me whether that lung is ready to be delivered or not. So it works really beautifully. What do I expect in the future from something like this, in a scenario like this? I know that the simplest form of artificial intelligence already calculates the fetal heart rate for me. What I look forward to in the near future is an AI-based detection of fetal cardiac arrhythmias, which means that the abnormal pattern, such as this one here, which is our most famous missed beat, will be picked up very soon. The second area where we use a lot of this stuff is the spontaneous preterm birth. We started working on the Garg cohort a while ago, but we know that that is something that is a very large project. And in the meanwhile, I've been trying out cervical length, works, doesn't work, 15 cutoff, 25 millimeters cutoff, 1 cutoff, I don't know yet. I've tried elastography, and irrespective of which type of elastography I try, I know that if I push a little harder, it's different. And if the cervix is soft, it's different. If it's hard, it's different. If its length is short, does not mean that it is soft. If the length is long, it does not mean that it is hard. Therefore, we shifted again to artificial intelligence from the same company that gives me news on the fetal lungs. And I just upload my standard transvaginal view of the cervix. Automatically, it's the same story, that the area of interest in the anterior wall of the cervix gets outlined. I don't have to do it myself, and it tells me whether I'm in a low risk. And then this is done at the standard 20-week scan. It tells me what's my risk at before 34 weeks of gestation and what's my risk at 37 weeks of gestation or less. And so I automatically have this. Does this work better than what I've been using so far? Yes, it works better than what I've been using so far. Has that been published? Yes. Has that been published many times? Yes. Has there been an external validation? Yes. So it's a clinical tool that is obviously available. And all we're trying to do now is to push in more patients so that we can bring the prices down to suit our patients here. Our patients can afford it, but they don't like to pay for it, and so we have to get used to it. There's also, of course, people who try to convince us that we're a poor country, but that's a discussion for the rest of the day. Now we move on to the other very simple thing, and that is that most machines can very easily today differentiate between fluid spaces and non-fluid spaces, which is cystic versus solid. And the first function that we ever had on that was, of course, my eye looking at the ovary. And then we realized we're getting a bit fed up with the number of follicles in those ovaries, particularly because 3 out of every 5 girls in our part of the world is now polycystic. So I used to sit and count and count and count and then measure, and some of these were oval, and then you measure 3 times. And so that was 45 measurements to be taken. Obviously, it makes no sense. That takes too much time. Now we just switch it on. The threshold for the cystic areas is set automatically, and you get an answer on the number of follicles, each of the 3 diameters. And in fact, you can relook at the machine to make sure it's behaving itself correctly. And then what do? You can add on a follicle in case it's not there. So you actually work with the artificial intelligence stuff, and you get to know on a chart just like this. We use exactly the same thing when we stimulate these patients for IVFs. And in this, we get to know how much the follicles have grown, help us decide what gonadotrophin we give them next. Also, their risk of ovarian hyperstimulation, and the formula is the same. This has now been upcycled to also looking at any fluid space. So we have a fetus here. I'm not sure. I think these are kidneys, but is this really the bladder sitting up in the fetal epigastrium, in the upper part of the abdomen? Well, it is, because there's this huge bladder, very tiny kidneys, obviously obstructed, which is why they feel like they have no cortex. And I have an answer on anatomy already. And here is another interesting one. This is at 12 weeks of gestation. I wasn't sure what this was sitting at the back of the neck. I wasn't even sure whether it was a neural tube defect or whether it was cystic hygroma. And the moment I switch on my proprietary study of fluid, I see that it communicates with the ventricular system of the brain. And then I looked at the kidneys and I said, oh, it's multicystic kidney, so I know immediately that I'm actually looking at a syndrome. So that's the kind of information. In fact, we use it a lot on a daily basis to get a better look at the fetal face. We know that the fetal face is a very important part of now identifying the fetal phenotype, and the fetal phenotype is an extremely important part to assess the fetal genotype. And with the 950 genetic tests available, we really have to figure out which one should be done first and which one should not be done. And so this little line, the green line that we see here, it used to be a straight line, became a curved line, and now it actually moves. The machine is able to move that line and shift it within the amniotic fluid, and it does that on a real-time basis. And it does it with even the newer engines, and so you actually get a complete fetal face instead of things getting cut off. That there can be several causes for this. I start looking at the femur and try and realize whether it's stippled or not and the rest of the epiphyses, and then I send it off to genetics. It's now become so simple to guide this just because of a very simple thing of my line of vision sitting in the amniotic fluid automatically. What else? Well, looking at this fluid, we've been able to also enhance the way we look at the nuchal translucency, which we know is central to our diagnosis for the risk rates of Down syndrome and other abnormalities. And the equipment on the right section will identify that cystic space, will measure that cystic space, and that's really helpful because A, it's a check for itself, B, it reduces the amount of keystrokes that I have to make, and C, is far more reproducible. And therefore, it becomes easy. With the same answer, I can also assess the intracranial translucency, which will tell me more about neural tube defects. So really what is happening with all these exercises, I'm reinventing radiology. So I've reduced keystrokes, I've reduced the need for highly skilled individuals, and we don't have enough to do the number of scans to suit the pregnancy. And AI is reliably simplifying and reinventing the way radiology is practiced today. And of course, it's not making radiologists obsolete because I have to check everything. And you can see I'm looking much smarter than I used to look a century ago. Correct? And that's important too. And then we moved on to stuff which I'm not using on a regular basis, but I hope to be using soon because these collaborations are starting, and that's anatomy recognition in the first trimester. Some of this is actually fairly advanced, and we're working also on the second and last trimester. And we hope that this becomes clinical soon. But what has really become a clinical tool, and I didn't realize is going to become a clinical tool so soon, is that the machine realizes where the image is not perfect enough and you go on to auto optimization. And this is now available on low-end machines as well. Also, that machines have learned to recognize body parts in terms of actually having, charming, we are now completely stuck. Let me try. Yes. So machines being able to measure everything happily on their own, and not just the basic measurements of femur length, head circumference, abdominal circumference, but the cerebellum, the area of the ventricular system, as well as the cisterna magna, which is the fluid pocket on the back of the brain. And these have all become one-touch affairs, so you don't have 150 keystrokes to go through, and you can look at it while it's happening, and you can see, yes, it's happening correctly. And this is not just with one vendor, it is with several vendors now, and again, it's just that one single stroke which helps me do my work faster, and it's under supervision, so it works very well. So like I said, it's now available, and one of our speakers today who is looking after this machine will tell you that it's giving me 80% fewer keystrokes and 90% less time, and the accuracy is 95%, which actually is much better than a fatigued radiologist. So we must realize that radiologists are also very, very fatigable, and so are fetal medicine imaging specialists. And then, of course, there is this wonderful stuff where the machine can recognize where to look, and 3D reconstructions happen automatically. There is also other stuff that we're looking at on a regular basis, and one of that is an improvement on the cross-sectional reconstruction of the heart. We used to call that stick, and then it went on to automation. The initial stuff and the lower pictures actually represent what we did in 2006, and we thought that was primitive, but 3 years ago, there was a major leap in actually looking at what happened to this. The voice is not audible well. Is that? Yeah. So we realized that this how about now? Yeah. So we realized that this wonderful tool has undergone major changes, and we have now changed the way we do that. Instead of trying to fit an actual template to the heart, we make 3 dots and we get all the sections that we really want. And because we've done this with other areas as well, we now have a full list where AI can recognize what's going on. It's done with a reasonable amount of quality control, and it actually helps you to refine the skills. Let's see how this works. So you're scanning and the machine says, ah, yes, okay, this is the profile, this is the right view, hold on. And it does the identification and it ticks them off on a list. You can take that list ahead, and in fact, the next step when you take that list ahead is this wonderful template that comes at the far end of the screen, which tells you that yes, your landmarks are correct. So it's actually reassuring you as you go along that you're doing very well, which means it's a tool that can be used by people with less experience and with people who don't have as much supervision, which you know is just so fantastic in our part of the world, and we need to handle that. And in fact, we've been able to cover all the 20 planes that we have on the ISWOG list. What is also possible is that it teaches you as you go along on how and what to do. So there is this wonderful 3D animation here and tells you in which direction to turn your transducer. So it's an automatic training tool as well. And we've now really simplified this. And you know these wonderful things that we've been discussing over the last 2 days, where we've in fact changed the 6-step protocol to an easier protocol in the Colopus project and doing such excellent work. What am I looking for in the future is stuff like this, where I don't have to send my data, and we learned about federated learning yesterday, but we have all these abnormals, and these heat maps can tell us exactly what to look at and identify pathology. We have this one wonderful paper from China, but we're hoping that we will have more papers like this. So really, I don't have to talk today about what happens in artificial intelligence and so on, but simple things like this. I triage patients who need a specialist investigation. I get decision support, I get assisted reading, which helps me be more efficient, and I get a structured reporting, which makes sure that every section is on it. And thank you so much for your attention.
Sir, we will be having questions at the end of the session. So after all speakers cover up. So you can join, sir, on this. So it's my pleasure to invite Dr. Deva, who will be joining virtually with us from Delhi. So he's a colleague working in a radiology department and is collaborating with us on the endocrinology projects. So may we have Dr. Deva online?
Thanks, Yashdeep. Hope my voice is audible and my screen is visible.
Yeah, Deva, you can go ahead.
Okay. So thanks for inviting me for all the organizers, and thanks for the introduction. After this excellent talk by Dr. Ashok Khurana, my area is a little different, and I'll also list few of our experiences in using AI-based tools in our daily practice. So just a brief introduction that AI been there for many years, but it has become mightier than ever. But that's mainly because of the deep neural networks. The traditional machine learning was not able to perform so much as we liked it to be, but the deep neural networks have totally changed the scenario, and that's the reason why AI has become a buzzword in the recent days. And it has moved from simple pixel based segmentation, which was actually a traditional ML based tools, to a tool which can make complicated diagnosis on radiological images. Radiology is a image based specialty, and the reason why A has A has more focus on radiology, but other specialties like ophthalmology, pathology, even endoscopic images will also follow the suit in the future. Although radiology is the first field, or one of the first field where A has grown in a huge way, but there are a few challenges in radiology. Medicine, as we all know, is not a precise science like computer science, maths, or chemistry. It involves a lot of complex variables. Any feature on radiology, it varies from person to person. There are other factors which are very subtle and difficult to perceive, even for a human reader or radiologist. So we always thought that imaging, radiology or imaging needs a lot of pattern recognition, and it's difficult for the computer to decode it, or what we call it as medical intuition. Medical intuition is something we always thought only humans have, and machine cannot have this kind of intuition, or it's very difficult to code this kind of medical intuition into coding lines or lines of codes. But this deep neural network has become a new thing, and it has learned this kind of medical intuition, the way we think and we look at images, and we learn about those features and changes over a period of time. Similarly, this neural networks also learn without even coding explicitly, and that's the reason why it has become a huge thing. So now what we considered as medical intuition, which is very unique to humans, is not the way it is now. So first we'll concentrate on text analysis. Again, text analysis is not a sophisticated deep learning algorithm, but it is based on based on machine learning techniques. What is text analysis? Radiologists, we generally look at macroscopic features of any image: cystic, solid, heterogeneous, calcification is there or not. But as like any digital image, radiology image is made of multiple pixels, and multiple pixels means multiple shades of gray in each of those pixels, and those microscopic features will not be able to see it, or will not able to appreciate as a human reader. What this text analysis algorithm does is that it reads all the pixels in the microscopic level and brings out those microscopic features or microscopic heterogeneity or any microscopic patterns in a very quantifiable way, which means that those things which are not able to visualize on imaging or with our naked eye, machine can bring out those features, and those features, when they are brought into a quantifiable parameters, it is called text analysis or radiomics. When radiomics is correlated with a genetic profile or outcome of any disease, it is called as radiogenomics. This is one of this is the radiomics pipeline. What we do in any process where we involve radiomics is that acquisition. Again, it should be a very standard kind of acquisition. We have to segment the area, which, like Dr. Khurana said, we have to segment that area clean, and which can be done using manual, auto, or semi-automatic segmentation. And the next step, which is called feature extraction, is the heart of radiomics, where the features are extracted, those microscopic features, shades of gray, and there are multiple things like first order characteristics, second order characteristics, or even higher order characteristics, which can be extracted from those images. More than 600 features can be extracted. Not all those will be utilized for the eventual calculation or eventual results. So we need to reduce the redundancy. We need to select those features. That's the step which is called feature selection. And we all also populate the data with the clinical info, genetic info, and all those things. And eventually we'll get the association between a particular radiomics feature and the genetics or the outcome. This is the entire pipeline of how radiomics works. And we used it in a particular scenario. This is a group of patients where there was a tumor, and it was a proven tumor. And this group of patients had an MR as a part of a previous study, and we wanted to test this radiomics tool on these particular tumors. This is a kidney, and there is a tumor in the kidney, and we initially segmented this area. And this particular software is a proprietary software. At that time, we didn't have our own particular tool for radiomics. So this particular software segments, after segmentation, it runs a proprietary algorithm, and it creates multiple images of different spatial using spatial filters. Once it creates multiple spatial filters, we get multiple features like first order, second order, higher order statistics. And I'll not go into the details of it because it is too complex and it's too mathematical. And our intention was to whether this radiomic features will be able to differentiate a particular histological subtype of RCC. All those patients had renal cell carcinoma, and just by looking at the image by a radiologist, we cannot, it's very difficult to say, or it is impossible to say whether it is a particular type of RCC, clay cell RCC or non-clay cell RCC, or it is difficult to say whether it is high grade RCC or even a low grade RCC. That's not possible just looking at the image. So that's what we wanted to try, whether this radiomics or can bring out those microscopic features and can find this differentiation between RCC, clay cell RCC from non-clay cell RCC, and high grade RCC from low grade RCC. And this is what these are the one of few charts in that particular article. This was published in recently, and we found that radiomic features, these are first order radiomic features, which can to some extent reliably differentiate low grade tumor from high grade, and also clay cells RCC from non-clay cell RCC. What is the importance of this? That this is all done based on images. There is no invasive method at all in this. Just by looking at the image, segmenting it, putting a tool which can extract features, and it can tell you whether this is clay cell or non-clay cell, and it can also tell whether it is low grade or high grade. This will have huge applications for the management purpose. Even before, I mean, obviously RCC cannot be biopsied, so surgery is the only option to know what it is. But if we can give this information prior-hand or beforehand, it can help the management. So again, we had this same group of patients in which RCC was there, angiomyolipoma was also there, and oncocytoma also there. So what is this lipid poor angiolipoma is? Typical angiomyolipoma will have fat, and it is easy to diagnose on imaging. But if it is lipid poor, if there is no fat in that lesion, it is very difficult to differentiate it from RCC. So whenever we look at a solid image, solid tumor without any fat, we have to call it as RCC, because we cannot differentiate it from lipid poor angiolipoma or a benign type of oncocytoma. This is what we wanted to look at, and we again use the same tool and wanted to differentiate whether this radiomic features can differentiate RCC from other benign tumors, which radiologists cannot say by looking at those images with their naked eye. And this is how we segmented those, and using those spatial filters, we got multiple images. This is just a representative image, but when we actually do the radiomics extraction, we'll get multiple parameters. So what we found was this radiomics tool can be used as a non-invasive tool to differentiate RCC from lipid poor angiomyolipoma and oncocytoma, which is again a big thing when you look at the nature of these lesions. All these lesions look very similar to each other. It's very difficult to say using our naked eye that whether this is RCC or not RCC, but using this feature extraction in radiomics, we can to some extent say that RCC, this is RCC and this is not renal cell carcinoma. It is something like a benign tumor like angiomyolipoma or oncocytoma. So this is the kind of utility which radiomics can provide. In fact, radiomics is not even, as I said, it's not a deep learning technique or something. It can be even a machine learning or a traditional machine learning method. So this is the third thing. This is also got published, and here we developed our own tool to extract those features, the texture analysis tool, in collaboration with IIT Delhi. And what we tried here was that can radiomics feature or texture analysis predict whether this particular tumor will respond, osteosarcoma will respond to chemotherapy or not. This was our thing. And we used diffusion weighted imaging, and we also used IVIM DKI technique to create multiple parameters. These are all quantifying quantitative parametric maps which are derived from those diffusion weighted images. We use these parametric maps to extract radiomic features. And what we found in our study was we used, in fact, in this particular study, we used a 3D statistical text analysis. The earlier thing were 2D text analysis. This is a 3D text analysis tool. We found that these tools can differentiate, predict which of these tumors will respond to chemotherapy or which of these tumors will not respond to chemotherapy. So what I mean to say that radiomics can help in deciding before undergoing a surgery or before undergoing chemotherapy in a non-invasive with just those imaging, with just those CT images or MR images. It can add much more value than what radiologists can look at and diagnose things. So what are the pros and cons of radiomics? It is not data hungry because it's not a deep learning technique, and there is no need to train the algorithm, and it can establish imaging signature with a particular genetic issue or a outcome of the patient. Computationally, it is simple compared to the traditional, compared to the neural networks, but there are disadvantages in this. You need to have a standard protocol of acquisition to apply this radiomics, because any change in filter or any change in windowing will affect the eventual result of radiomics. And that's the reason why there is no current consistency among different institutions in how it should be applied and all those things. That's one of the issue in radiomics. This issue is not so much there in deep neural network based AI. This is a second scenario where we get a lot of pediatric patients. We need to find out the age or estimate bone age estimation in pediatric patients. It is unlike adults. In pediatrics, what happens is that the bone age is quite dynamic, and it's very difficult to predict the bone age or estimate the bone age. So we have an atlas called TW2 atlas or GP atlas, depending on the institution. And what we have to do is that we have to match each and every bone with the existing photo in the atlas. It's a very tedious process, and it takes almost 10 to 15 minutes depending on your expertise. So it's a very tedious process. Now we have an algorithm or a tool. This is again a proprietary tool which works on a particular image. It happens in a over a period of 5-6 seconds. In 5-6 seconds, it can outline the bones. It will match the outline of the bones with the existing thing in the atlas. Either it is TW2 or GP atlas, and it predicts the bone age. At the same time, it can also predict the adult height of the child in future. So it really reduces the load, and it really reduces the time and the tedious process, because we have to match each and every bone with the existing atlas. It's a tedious process. These kind of AI tools can really bring down the time. We just have to feed the digital data into the machine. The results come out in few seconds. So this is how the algorithm works. I'm not going into the details. First, it will reconstruct the bone borders using the AI technique. And once the borders are figured out, it will match it with the existing database, and it will come to a conclusion, or it will predict the age of the bone age of the particular individual. So now I'll give an example of our team worked on something involving a neural network. Neural networks are data driven. It doesn't need explicit coding. We don't need to tell, we don't need to code it in a way that it should, so it learns over a period of time with the data. That's why it is data driven. And again, the negative part of that's again the con of the CNN. It needs a lot of data because it needs to learn, because there is no coding, explicit coding involved. So it needs to learn, and it takes time for that learning period. So it takes there is a lag period from when you start training it, and when it reaches till it reaches a point where it can perform in a good way. But once it is trained in a proper way, after a period of time, it performs better than traditional machine learning algorithms most of the times. Because traditional machine learning algorithms, there is no need for training. They are explicitly coded, whereas CNN needs training. And once it gets trained, it can potentially work better than ML applications. So this was again a study where we wanted to try CNN algorithms to differentiate COVID, to pick up COVID positive patients just based on chest X-rays. And this in the study, those X-rays which were labeled as COVID positive by radiologists that were not introduced into this algorithm, those were considered as final diagnosis. But only those X-rays which were labeled as negative by radiologists, but those X-rays were taken to train the algorithm. And what we found was, even in those which were found to be normal or labeled normal by radiologists, even those cases were picked up as abnormal X-ray using this algorithm, which means that AI can pick up. It has a sensitivity better than better than the radiologist, and can pick up more number of positive cases. I'll give you some examples. In fact, the sensitivity increased from 65% in case of radiologists picking up those findings to 80, I think around 80-85% when we include this algorithm into the system. So this is one of those examples where this is a COVID positive patient. There was a lesion here. This was labeled as COVID positive by radiologists also, and machine also picked up those findings here. This is a heat map showing why it decided that this is positive or negative. And this is, we know that there is a lesion here. So the machine learning technique also identified that this is the lesion. This is the reason why it called it as COVID positive. This is another patient. This is again a COVID positive RT-PCR positive patient. Radiologists labeled this as negative, but machine found that, or the algorithm found it as COVID positive. And we want to try to find out what is the reason why it said this as COVID positive. Was the heat map or the rise map showed this area, which is not the area where we look at the features of COVID in any patient on chest X-ray. This is a heart where it is pointing towards an area where there is heart and lung is clean. So it's very difficult to say why the machine called it as COVID positive. But we found this particular scenario in many patients where radiologists called it as negative, but patient was RT-PCR positive, and machine consistently pointed out this particular area in the heart. And this is just a hypothetical point that, and maybe the COVID can also affect the heart, and it can present with cardiomegaly, pulmonary arterial enlargement. All those things can happen in COVID, which radiologists, as in a routine reporting, we ignore those changes. We generally look at the lung changes, and we tend to diagnose based on just on lung changes. Maybe the machine looked at some feature in the heart which generally associated with COVID positive patients. So this is just a hypothetical thing we brought out in this particular study. Still needs to be proven, but this is the ability of a CNN or neural network. It can sometimes perform this superhuman type of detection. It may be true, it is maybe a false association, but it can give you an idea that maybe this is a feature which we need to look at. So it pick up things which we never thought it to be. And this is an example of a patient where radiologist said it is negative, and this patient was RT-PCR negative, and machine also told that this is negative. So what's the pros and cons of neural network? It is data driven, does not need explicit coding for the features. So there is scope for constant improvement because it learns with the data which we give, and it can do intuitive and complex tasks. It can achieve that medical intuition which always think which is a human thing to have, and it has the potential to outperform other methods. But again, the negative side is it is data hungry, it needs a lot of training time, and there is one issue of no explanation of why it decided something, which is called as black box or opaque box. I think that we never get to know that why it decided something it did. But although there are few methods or algorithms not now available to decode that process to some extent, but it is not completely exposed. We also worked on a algorithm recently to pick up nodules on CT scans. I know SCAD is available, or computer aided detection is available for a very long time. But the problem in CAD is that it is not always correct. It sometimes misses a nodule. Sometimes it detects the vessel or something in the lung, and it marks as a nodule. So it is not a good method. Its accuracy is poor. And when we want to mark those nodules manually, it takes a lot of time because it's a tedious process, and especially if you want to segment all those nodules, it takes a very long time if there are multiple nodules. So we took a semi-automatic approach to harness best of both worlds, and we created a tool again in collaboration with IIT Delhi. And what we need to do is that just put some dots on those on those nodules, and the machine itself will segment the entire nodule across multiple sections. We don't need to draw that ROI at multiple sections because those are thin sections. It takes a lot of time to mark those areas. What the tool does is that just put a dot and say this is a nodule, and the whole nodule, because using the seed growing algorithm, opacifies, or it segments out the entire process without us having to mark out individual areas. So this is an example of that. This is marked by a radiologist, and this is marked by the machine itself. This again, the blue one is marked by the radiologist, and machine also did a very decent thing to mark out the nodule. In fact, when radiologists mark out this kind of tiny nodules, we always tend to be erroneous. Either we mark the area too much or mark the area less. Because it's a tiny nodule, our mouse movement is not that accurate that we do it in a very particular way. So machines segment those nodule. If you use the seed growing algorithm, it segments that nodule in a very accurate way. This is another example of, again, if you look at this, the nodule within the blue is the actual nodule. And in fact, the radiologist had overestimated the nodule, whereas the segmentation algorithm did it in a very accurate way. So other applications in radiology is that nowadays there is a lot of automation of CT scan acquisition and MR acquisition. We just need to put the patient on the table and choose a particular protocol. The machine can choose the right plane, FOV, and do the scan on its own. And even the reconstruction of CT and MR, machine chooses on its own what reconstruction is best for this particular scenario, particular habitus of the patient. Patient is obese, thin, what kind of reconstruction should be used. Everything is done in an automated way. This is all due to AI. Just a couple of slides about black box problem. We know that in a deep neural network, when we give the input, it goes through multiple networks and the output is given to us. But in between, what happens, why this particular decision was made, it is very difficult to know. And that's why it is called as black box thing. And why it is important to know what is happening inside that black box is that without knowing what is the reason behind this problem, without any logic behind it, it's very difficult to understand and believe the machine's decision. And also surgeon cannot operate because AI said so. So, and it's also important when AI goes wrong, we can understand at what point AI went wrong and what was the reason it went wrong, and we can tweak the process and change it in a way that it learns. So unless we decode this process entirely, it is sometimes difficult to believe the process. So there are various methods which are being explored, but this is still an area of research. I mean, in an example which I showed there, machine can still show the heat map, and this is the region why this is the region of abnormality, why the machine said it is COVID positive or negative, but it is difficult to fully understand why it said so. So that is important to know, because can be corrected.
So I think there is some connectivity issues, and in interest of time, I think we can move to the third speaker.
Maybe we can wait for a minute. If I think he's joined back. Yeah.
I got disconnected.
Yeah.
Glad.
I am not sure where I got disconnected, but this is my
You
last.
were at the black box.
Yeah. Okay, sir. So not long. Okay. So why it is important to know whether there is why it is important to know what is going inside this black box is that without understanding what is going inside, it is very difficult to believe the AI and its decision. Surgeon cannot operate just because AI said so. Surgeon has to understand why the AI made this this decision, and that should be logical enough to go and do something like surgery. So that is important, and we, if we know what is going within that black box, we also learn from those AI algorithm, whether, I mean, okay, maybe AI found something which is unique, and we have to incorporate in our own clinical practice. Or maybe if the AI goes wrong in that particular area, we can point out, okay, this is the reason where AI goes wrong, and we should know this. So these are things which we will get to know if we decode this black box, what happens actually, what is going inside, which is called as interpretable artificial intelligence. And it is my last slide. So AI algorithm is getting better and better, and now it has achieved an accuracy in many areas equal to that of an average radiologist accuracy. And currently the ability of AI is restricted to a single organ system. But there are some diseases where where you need to collate information from multiple organ systems, like systemic disease and all those things. Also, we need to add on features from clinical side, biochemical side. So I think AI has not progressed to that level, and that will happen sooner or later. But multimodality interpretation is not yet there in terms of AI ability. And as we discussed, AI, we cannot blindly agree what AI says, and we need to interpret with the clinical background. And it's very important to know what is going behind that decision, why particular AI algorithm did this. But currently, what I think is that AI is matured enough to replace multiple mundane tasks like measurement, ROI marking, or even vertebral level marking. Those things which radiologists time is getting wasted, to mark out multiple areas of a nodule, multiple vertebral levels, or doing routine measurements. It takes a lot of time for a radiologist, and it is not that difficult to do it using AI. So I think AI now has the ability to take over those mundane tasks, and it can do all the background while we qualitatively interpret those images from head to bottom, head to toe. In the background, AI can work on those measurements and all those basic things, and it can chart it on your screen. So at the end of the report, you can see it, can have a cursory look at it, and if it is okay, it's like a checklist, and things can be done like this. So AI has matured enough to do this job, and it has a lot of scope. It will reduce our radiologist time, and that can be used in a more productive way. Thank you so much.
So thanks, Deva. I think the two lectures by Dr. Khurana and Dr. Deva has set the ground for discussion. They have highlighted the different aspects of from a clinical perspective. So may I request Dr. Pramod sir to introduce the next speaker?
Thank you, Yashdeep. The next speaker is Dr. Abhinav Jain, who is an experienced radiologist and academician, having worked both in private and public healthcare sectors. He has vast experience working with different radiology techniques, and is a much sought after teacher with innovative interactive teaching and learning methods. He has been awarded President's Appreciation Award for contribution to radiology imaging and teaching by Indian Radiology and Imaging Associations. I request Dr. Jain to come and deliver his talk.
So we have heard a lot from experts, and now I'm not going to take you through any of the slides. What I'm going to do is just I'll share my experience, what it has been from a perspective of a radiologist who is working in the clinic, not with proprietary softwares like privileged positions shown by Dr. Khurana and Dr. Deva. So what I'll tell, what we have our experience with the commercially available softwares which we have been using for some time now. My first exposure to artificial intelligence happened when we were approached by different companies who were producing AI-based algorithms to collect data from us, and later on to label them and annotate them and all that. But the real thing came in when I met Condi, and he took me to those workshops and introduced the real concept of AI, how actually it is working with those convolutional neural networks, and the workshops which I attended with, which Madam organized, Dr. Patnagar. So that's where we actually got to know how much efforts have been put in to reach to what we want, and we can want to reach moon. Like Dr. Alice yesterday showed us how much of effort goes in to actually visualize the perception, the hand movements and coordination and all those to reach to some kind of software. So yes, we are in a development stage, and it will definitely take a lot of time. Although what Dr. Khurana has shown today is really fascinating. I have not had an opportunity to work on those softwares, and yes, that is something which is very desirable. So what my colleagues and like I work with a team of around 20 to 25 to 30 radiologists. What we felt about the AI softwares and algorithms which are available to us, I'll just give you a perception of what they felt. So from those who were like senior faculty members who have had experience of working for a long time on in radiology, they were not very willing to accept these changes. They were like not forthcoming to accept it, because many a times there were problems when these softwares were being used. So they were like, we can do it better. Why should this has inherent problems, and maybe a resistance kind of thing was there. But most of the younger faculty and the residents were very forthcoming, and they started using these tools. And when we collaborated with him for this development of this his project, and there a lot of residents came forward and they started doing these measurements, because it's actually a tedious job to take 3 measurements for each scan and then come to some conclusion. So also there was a lot of resistance by the medical educationists. This concept was discussed in our medical education unit, where they said that if you have a software which or a AI algorithm which is going to give you the diagnosis, how the students or the learners will reach to that process of approaching that final diagnosis. Most of the times the auto features would rather give you the final diagnosis. Let's say that this particular area is where you have the problem. Now, but the real learning comes in when the student approaches it from start, when they see a lot of normals, and then they start recognizing the abnormals. So maybe somewhere the educationists will have to come in, and artificial intelligence tools may be an assistive tools at later stage, but the real learning during undergraduation, post-graduation, and even during the senior residency should be without artificial intelligence as of now. So this is something which most of our colleagues pointed out. So I just thought I'll share it here. Then as far as automation is concerned, in my department and in my area where I'm working, automation has happened at most of the levels, whether it's at the billing counter where we are triaging the patients which are in emergent need are being highlighted and they're being sent over for an urgent scan. The waiting times are being calculated with special algorithms. One of the companies is there doing that kind of work, and that has really helped. There were long waiting times for ultrasonography, especially with around 200 ultrasounds being done in a day. So this kind of automation there has given patients a much more relaxed environment where they can actually know their a possible time of a scan, and then we can schedule them accordingly. The best feature was that this algorithm has also started evaluating how much time a particular radiologist would be taking to do this kind of scan, and therefore this can also be one of the features which can be utilized. Then coming on to the scanning techniques, yes, scanning techniques have been improved quite a lot, whether it is X-rays or ultrasonography or CT or MRI, especially in X-rays where the variety of technologists which we have who are not very well trained, and especially when it comes to like you are doing a chest X-ray PA view, which is done on a routine basis, or a knee X-ray, that they could do easily. But whenever it came to special views like a Schuller's view or maybe some other mastoid view or something which is not done routinely, then they were stuck. And the machines now have special capabilities where they can actually guide them to do the scans in a proper way. And rather recently we have acquired a machine which can actually automatically position the tube in a way that this positioning factor can be eliminated. So such kind of automations are being very welcomed by everyone. We are getting good desirable images where we were not getting. So that's something which is one area where the AI can be used, and acquisition of images, the positioning, the technical factors like the amount of KVP MAS which is to be given to acquire a particular image, and how you can further reduce the radiation dosage by using maybe some AI features wherein the radiation dose can be tailored according to the amount of the patient's body habitus, the age, the gender, the specific areas of regions which are being scanned, and that would be really of great help. Coming on to the interpretation part, we have already seen the advanced interpretations which are being done with the help of AI. Personally, we have not been so far able to be very convinced with the interpretation part of the AI, although the results are promising as I saw today. And other than that, of course, our personal experience has been with the Sono NT, the nuchal translucency measurement scans, and automated intima-medial thickness IMT. These things have been there, but the challenges still remain. I mean, one of the questions which has been coming up again and again to us is like, if there is a mistake which has been made by the use of AI algorithm, who will be responsible for that? My residents are always after me, like, if we are using it and something goes wrong, then who will be sued? I mean, is it going to be our responsibility or the person who has delivered that AI algorithm? So that's another thing. And in ultrasonography, like Dr. Khurana has nicely demonstrated with all those images, we do have the auto measurement facility. Is it there? So I'll just show you one small clip which I captured before coming here. So while we are doing a particular scan, so let's say this is a section of the abdomen, and when we capture this abdomen, we have to sweep through the entire fetus, and we reach to a particular section. And this automated software would rather, the moment you are in the correct plane, it would measure the abdominal circumference and in all types of ways you want. Similarly, there are other that's it, thank you. There are other parameters like biparietal diameter, head circumference, and transcerebellar diameter, cisterna magna, and all these can be measured. That's it. I don't require. Thank you. So these are the things which you can do, but again, there was a problem here when we were measuring these actual diameters. The person who was measuring, if he doesn't reach to a correct plane, the AI tool usually fails. It doesn't measure the correct biparietal diameter there, and we get very wayward readings. So then ultimately we end up measuring them. So that's one problem which we have faced. Then coming on to the advanced software AI applications like 5-dimensional CNS or Sono CNS and Sono other things. So there the softwares have been, the AI tools have been developed where you can actually get a three-dimensional data and capture the head maybe of the fetus and reach to a particular level, and then you label it and you get a get all the planes, as sir had beautifully shown in the morning. But what happens again, if you are not in the right plane and you cannot control the fetus would move. The whole data gets spoiled, and what we get is actually not of diagnostic value. Maybe the advancements have happened now, and there are better AI tools which can actually capture all these planes in a beautiful way. But in my experience, we could never use it. We started with using it, but after it was just 2 years back we acquired it, and now no one is using it in my department. So it's just lying like that without any actual practical use. So maybe with the this is something which we look forward for. In CT and MRI, a lot of automation has happened, and especially radiomics, which we heard just now. Other than that, what we have used it for is again for the positioning of the patients to set the parameters right and tailor the imaging protocols according to the particular patient need and the clinical indication. So this is something which I feel should be the priority area now, that the technical details, especially the radiation protection aspects and image acquisition, they should be worked upon, wherein we can actually capture the right images and then we can build upon the interpretation of those images. So if I would put it this way, that if I have to do a nuchal translucency scan in a 12-week fetus, then I have to spend a lot of time, maybe 20 minutes, 25 minutes. And as Dr. Khurana, I heard one of the meetings with Dr. Khurana that he had to wait for 4 hours to get the baby in the right plane. So this is something which is actually the case. And what I see, most of in busy departments, the residents end up with getting whatever they can rather than waiting to get the best possible scan. So if you can, if the young researchers could work on something where if you have a suboptimal image, you get a 3-day data, you align the fetus in such a way that you can get into a correct plane, and then we can do the measurement of the nuchal translucency. So this is something which can be worked upon. Also, I had that fetal echocardiography in mind, because most of the radiologists who are working in the private practice or even in the government setups, they do not have that much expertise in the fetal echocardiography. Most of the times when we get stuck, we have to refer them to Dr. Khurana in Delhi, and then he would come up with the solution, and we look forward for his reports, and then we again try to see what we had missed on. So that's but I feel at times we are too much disturbing him with all these things. So somewhere where you can develop that. So I told about auto VCAT. Yes, I'm yet to see that, but something like that would be a welcome thing. I saw one of the posters which talks about fetal echocardiography from IIT. So yes, that's one area where we would love to have automation, where we can get useful information. But as I was mentioning earlier in yesterday, that if we have a software which, if the AI algorithm filters out the important information also, that's going to be a trouble. There we are very skeptical. If something goes missing, then what will happen? So the automation has to happen, but it has to also assure us that the findings will not be missed in this way. And you have to be very careful while developing these algorithms, that important informations, even if they are subtle, they should not be missed. Again, filtering out this brings me to filtering out the normal chest X-rays, as we saw a lot during the COVID times. Many places were flooded with X-rays, and there were people were not there to report them. So this thought of filtering out the normal X-rays came in, and many people, even my management, approached that since you have shortage, then why don't you buy one of these AI features where we can filter out the normal X-rays? Yeah, that does help in those times. But again, I would say that uh, this should be restricted to use after a certain level of competence which a person has acquired. Because again, seeing the normal X-ray and looking at the normal variants, maybe a cervical rib, maybe a azygous fissure, something which would help a radiologist later on to give a good interpretation of things should be kept into mind. So that's much about it. I mean, I'm open to all kinds of questions, but yeah, this is the brief what I could talk about, and that's what my personal experience is. Thank you.
So thanks, Dr. Abhinav. I think you have raised very pertinent points, especially the academic perspective of AI. So I think Dr. Soumya, after 3 radiologists, it will be of interest to see what Dr. Soumya to speak, because he's a gastroenterologist, a very busy clinician, and how he manages to incorporate the AI in clinical practice. So Dr. Pramod is a mentor. Maybe he will add once Dr. Soumya speaks.
I'll just only say that
Sir.
Soumya is one of the rising stars in gastroenterology, who is not only a clinician and an excellent endoscopist, but also someone deeply interested in academics. So I think he's the right person to tell us how AI is going to help clinicians actually manage patients. So over to him.
Good morning, ladies and gentlemen. Good morning, Professor Garg. I would like to thank the organizer for giving me this opportunity. So can we share the slide? So can you put it on slideshow mode? So over last few decades, artificial intelligence has been integrated to field of clinical medicine as well as gastroenterology. Initially, it was some computer-aided programs that mimic human cognitive functions such as learning and problem solving. And over time, with machine learning algorithms, we could analyze data and we could develop predictive models. And over last decade, we could use this deep learning. Those are convoluted neural networks and artificial neural networks from which we can capture data from the images, process them, teach the machine with the data, and then simultaneously interpret the data with the help of a machine. So over in the field of medicine, over last decades, there has been a bombardment of papers for artificial intelligence, machine learning, and recently the neural networks papers. So in field of gastroenterology, where we use artificial intelligence, predominantly in endoscopy. In endoscopy, when you do a upper GI endoscopy and a colonoscopy, since most of some of the attendees here are from IIT, I would like to say when you do an endoscopy, you put a tube at the tip of it, there is a video processor and which take images, which take a video from the intestine till the stomach, and we can do a colonoscope through which we can visualize whole of the colon. So our intestinal tract is 6 meters and the proximal 1 meter, we can visualize the upper GI endoscope, and the mid part we can visualize by capsule endoscopy, and the distal part we can visualize by a colonoscope. So in endoscopy, we get a lots of images, and those images can be used by the artificial neural networks to build to train the machine, and simultaneously that can be used for detection of cancerous or precancerous lesion during endoscopy. We can also use to differentiate between benign and malignant lesion, and we can identify some, if the patient has a GI bleed, we can identify the lesion which might cause GI bleed. And this can be used, this machine learning algorithm can be used in medical data when the patient population is used, which is in thousands, then it's very difficult to do it manually, and we can use machine learning algorithm to build prediction models, decision curves. So this we have discussed yesterday. So this is a and colonoscopy photo. So while you're doing a colonoscopy, in the panel A, when you do a colonoscope, normally we see this is the figure. And if you use an artificial intelligence software, which is an additional software which can integrate into our endoscope, it can point out some blue boxes which may be of some interest. So if on the panel A, if I do endoscopy, usually I would say it normal and progress forward, but my artificial intelligence software points out this area which you need to focus. So out of all this areas, so the middle box, I think there is some abnormality. So I took a closer view and I think that's the abnormality. Then when you do a narrow band imaging, I think that's a small tumor, which may be a benign tumor, which is sitting over there, which is a smaller size, maybe of 2 to 3 millimeter. And I might have missed when I did do an endoscopy. And if you take out that tumor, the histopathology shows, yes, that's a tumor. So this is the benefit of using artificial intelligence software to our endoscopy for diagnosis of cancerous or precancerous lesion. So there is a study which have shown that, which is published in Lancet, which which used a deep learning computer aided detection system for adenoma detection during colonoscopy, and it has shown, as compared to the control, the computer aided detection group has higher odds of finding the cancerous or precancerous lesions such as polyps and adenoma when we do a colonoscopy. So not only we can identify the lesion during the colonoscopy. So if you can see, this is the figure, we can identify the lesion, and we can, with deep learning techniques, we can say whether the lesion is a benign gastric ulcer or whether it is a early malignancy or whether it's an advanced malignancy. So this is a figure where there is a lesion in the stomach, and this lesion appears to be a early gastric cancer, which is detected by this deep learning methods, by artificial intelligence models. And after that, we can also predict what is the depth of the lesion. If it is a early, so it's important to differentiate between a early gastric cancer and an advanced gastric cancer. If it is a early gastric cancer, sometimes we may be able to resect it, take it out by endoscopy. So sometimes we do some procedures like endoscopic submucosal dissection, endoscopic mucosal resection. So by that techniques, we can take it out endoscopy so that you can avoid a surgery. So if it is a early gastric cancer, with the help of AI assisted model, we can say what is the depth of invasion, and we can classify whether it's a T1A or T1B tumor. So it not only diagnoses, not only identifies the lesion, it may be helpful in diagnosing the lesion and predicting its depth. So if we, so these are few photographs. So on the panel A, as you can see, the panel A and B, both of the lesion are primarily malignant, which is, as you can see it on our visual examination, which is also being identified the computer aided software. And on the right side, C and D panel, those both lesions are benign lesion. So if we, so there was a study which compared deep learning algorithms, computer aided AI aided computer aided detection techniques to the endoscopy, which is being done by a novice, an intermediate, and an expert. So if you see the performance is so performance is equivalent to an expert. So in early phase of career, it was proposed that people can use this AI based algorithm to increase their tumor detection rate. So this is another example when the patient has Barrett's esophagus, and with the help of AI based algorithm, we can detect neoplasia with high accuracy. So artificial intelligence in endoscopy helps us to improve navigation so that we can reduce miss rate of the tumor. Computer aided detection technique can help us to take to identify the abnormal area so that we can take targeted biopsy from that lesion. Computer-aided diagnostic techniques, which involves predominantly the neural networks, and it may help us in prediction of the histology of cancerous and precancerous lesion, and it can help us to say how deep the lesion can be. It can help in demarcating the border of the lesion so that you can correctly identify the lesion and take it out as a chunk, either in endoscopy. So nowadays it can help us to identify the blind areas during doing an endoscopy. So during doing an endoscopy, there is some area which is not seen well during through the endoscope. So you can identify some blind areas so that you can turn your knobs to focus on those areas also. So so for small bowel is a small intestine is a 3 to 4 meter of intestine which is not accessible by endoscope or colonoscope. So this is a wireless capsule endoscope. So we advise the patient to take this capsule. This capsule takes photos at a frame rate of 4 to 6 frame per second as it passes down the intestine through peristaltic activity. The capsule takes pictures when it passes from the stomach to the small intestine to the colon, and all the pictures are stored in a software, and subsequently we review the software. So the whole video is the capsule takes for 12 hours, and to analyze the to read a capsule endoscopy video, we will take at least 2 to 3 hours because there are lots of photos. So we try to use our convoluted neural networks. How can we minimize the time of examination of the capsule endoscopy video? So as you can see on the left hand side on the upper panel, all the frames capture same images. So we try to drop those frames, and these are the cropped and masked images which are of no significance. So we try to drop that. Subsequently, we use those convoluted neural networks by cropping, masking, resizing, augmentation, and standardization. And subsequently, we got that output. So if you can see in the upper panel, there is a first image is a polyp, second image is angioectasia, third image in ulcer, which can be easily picked by the heat map, which is being produced by our artificial intelligence based convoluted neural network based softwares. And if you can see the final panel branch 4, it can very well identify and focus on the lesion so that you can easily identify during your subsequent examination of capsule endoscopy. So if we compare this with standard technique, the accuracy, sensitivity, specificity, and precision are very high as compared to the standard techniques. Subsequently, we devised a technique using transforming input of color space in tandem, THSTI, convoluted neural network, so that we can classify an image on the basis of its heat map to whether it is a normal or there is some abnormality. That's a binary classification, so that you don't focus on the normal images, you focus on the abnormal images, so that the chances of getting a lesion is higher. So if we move a step forward for transforming this machine learning algorithm artificial intelligence for prediction model or personalized care, this is an example which is published recently in patients with gastric cancer, suspected gastric cancer or high risk of gastric cancer. If you take this patient with chronic gastritis, if we combine the patient characteristics such as age, sex, comorbidities, medication used, or H. pylori is present or not, we can take some endoscopic features, we can take some histologic features, and we can club them. And that's a massive data. We can do a machine learning algorithm, and they have predicted a gastric cancer risk for which is whether it is low or high, and they predicted a personalized risk for the patient. So that if you have these characteristics and these endoscopic features and these histological features, what is your chances of gastric cancer in next 5 to 10 years? And if it is high, then you should get endoscopy follow-up frequently, and if it's low, you can get it at 5 to 10 year interval. So this is another example in which they have taken around 23,000 patients data from a database, and they have predicted if you have a colonic cancer, what is your chances of survival after resection for the next 10 years using a gradient boosted technique. And they have devised a personalized algorithm as shown on the right side of the panel. So over last decade, artificial in every journal of gastroenterology, at least 2 to 3 articles, mostly in endoscopy and also in the major journals, are from artificial intelligence. So what is the viewpoint of a gastroenterologist? So some believe, yes, it may be a third eye for a gastroenterologist while doing an endoscopy. You can identify the lesion which we were missing. Some believe you are focusing too much on the area which is being focused by the AI software, and you may miss the residents may get de-skilled. So it may not be a good way of training. However, over last decade, it has not been incorporated to our daily practice. We are still way behind of incorporating it to daily practice. The reasons may be the reasons may be high cost of this computer assisted detection techniques. These are sold as a separate add-on, so you need separate space, and some endoscopists are not comfortable with that. So we need to overcome this barrier over in near future. So what I expect from artificial intelligence in the next few years. So if I do 30 endoscopy in 5 hours, there may be a detection rate of 2 per 30. That's a pure hypothesis. So we have a limited time. We have to do too much of endoscopy within that time. So with AI, the detection rate may increase to 3 per 30, which may not be the case for an expert, and which may be a case for a trainer, for a trainee. And I think that's good. But now the AI based techniques, they have a very high false positivity rate. You need so when you're doing an endoscopy, it points out to area where it is nothing. As you can see on the right side of panel, there is just food particle which points out as a polyp. So you just take too much of time to focus on the area which is being pointed out. You may miss areas which is being not pointed out, and there are some minimal finding which is not so obvious. So we need to improve on that. So we need more so when our data is massive, if you have a data of 1,000 or 2,000 patients, I would like to so we need artificial intelligence to develop a prediction model. So I will just give an example. If a patient has a chronic pancreatitis, which is a chronic inflammatory disease of the pancreas, some patients do very well, and some patients have a very bad course. We need surgery, and they have poor response to endoscopy and other parameters. If the patient present to my clinic on the day one, if I say the patient has this type of presenting phenotype, this is the CT or MRI finding or ultrasound finding, this is the cause, and day one he's in clinic, and he asked me a simple question. Tell me, doctor, what are the chances of me having a good course or bad course? What are the chances of me having a surgery, and whether I would respond to therapy and whether I'd not respond to therapy? And so I would need, apart from our conventional statistical analysis, the data set is used, you would need help from a data scientist to work on this and develop some predictive models and develop some to accurately predict for that patient what is the need of surgery and how will be his next few decades. So we're working on this. Dr. Kondi will be helping me on this, I believe. And Since we have been discussing a lot on ultrasound, so we are gastroenterologists and we also do ultrasound. That is an endoscopic ultrasound. We place there is a ultrasound probe which is being placed at the tip of the endoscope, and we visualize this from the stomach, the pancreas. So sometimes in patients, we can differentiate whether it's a benign or it's a malignant. So till now, software are not much adequate to tell us whether it is benign or malignant on the, so we can have some clinical data and some imaging findings to predict that, but we have not till time applied at CNN to this field. And if you have a high chance of predicting that this lesion is a benign, so we won't put a needle into that and take a FNA. That will, we can avoid that. And if you have a very high chance of malignancy, definitely will take a biopsy, or you would take a better subject to patient surgery. So maybe over time we can answer this question. So thank you very much.
So excellent work, Dr. Soumya. I think you are the one example. Hello.
Thank you, Soumya, for an excellent talk. And I'd like to thank all the speakers who have given wonderful ideas and shown their data. I think we are all deeply educated in AI in healthcare. And I would like to congratulate Dr. Shinjini Bhatnagar, who has been the force behind organizing this wonderful conference and this wonderful session on clinicians' perspective. So my compliments to her and congratulations to her for this very successful conference. So let's have some discussion and questions from the audience. Before the audience take over, I'll use my prerogative as the moderator to just dwell on this. So my perspective is that when we talk about AI in healthcare, we are talking about two things. One is the automation part, where you want to reduce the dependence on an expert. For example, Dr. Khurana, and say, no, Dr. Khurana can't be everywhere. You do this kind of scans, send these scans to a particular place, software will detect what the abnormality is. And I think Calopus is an attempt towards that, where the ultrasound for fetuses can be done at a facility where expertise may not be required. And to some extent, what Deva said, that automation is already there in terms of labeling and measuring and other things. The second component of AI is where humans cannot see what the computer can see. That is what they was mentioning, that you can't really find out the histological subtype on visualizing the MRI scans, but the computer can tell you that. So I think these are two different things we are talking about. So in terms of AI, I think the first goal, Dr. Khurana, may I ask you, is it possible to reach the first goal rather quickly, if not in all areas, in some areas? Although I realized Dr. Jain was skeptical about the whole thing, but I think there are some areas where we can have some kind of automation. Over to you.
Thank you. That's a marvelous question. Can you hear me?
Yes, we can.
Okay. So the first goal really is to make sure that every pregnant woman gets a scan. We decided by the Ministry of Health, the Government of India, 9 years ago, that every woman must have a 20-week scan. We don't have staff to do a 20-week scan. We have equipment to do a 20-week scan. We don't have skilled staff. So we do need something somewhere to make sure that it can be done. The second problem that we have is that skilled personnel are not willing to go into places where patients get pregnant. Everybody gets pregnant everywhere. And radiologists and fetal imaging specialists don't wish to live in those places because of whatever reasons. And we need to make sure that there is a certain basic degree of quality being maintained there. And AI is a fantastic way of creating quality where none exists, because it can recognize a pattern. And second, making sure that it itself is satisfied with the quality. And the third thing, of course, is measurement. So it's really going to be the answer
And the aim is finally to make sure. The question that is often raised is that in ultrasound, we have the huge problem of sex determination. And the great news is that at THSTI, Ram and his team and Dr. Srinivas's team really have developed a pelvic masking. So if we put that onto equipment, then we know that it will not be misused. We've also realized that we shouldn't worry too much about that aspect, because people who come for a clinical scan are already aware of the fact that at 13 weeks, they can go to whichever shop and get the answers that they're looking for. So whoever comes in for a 20-week scan is way beyond that anyway. But that is something that's not to do with intelligence. That's something to do with the way our country is run. The second aspect is prediction on whether a texture will predict a particular finding, such as benign or malignant, such as those which require biopsy, or is this lung mature or not, or is this cervix not right or not. Yes, we've made tremendous progress, and these are very well researched before they come into the clinical domain. The third question is the cost of converting artificial intelligence into something which we will be discussing in the next session. But the fact is that industry has been extremely supportive, and we seem to be working in the right direction.
Thank you, Dr. Khurana. Yashdeep, you could take some questions from the floor if there are any.
Thanks to all the panelists for a wonderful session. It's Anurag Agrawal over here. By the way, Soumya, I loved your last slide. After 6 months, you find out it's really, really difficult. That's how it is. So I want to continue on that line, and a couple of questions are just clarification, something that was said. One, Deva, you had mentioned idiomics. There is no need for training. Of course, what you probably meant was there is no need for training to extract features, because you are providing the features. There's always going to be a need for training sets and validation sets, and that will never go away. But coming now to, I think we also heard some of the reasons across the talks of why AI in medicine is a problem. That's the way I would see it. Because many of the studies, especially one Dr. Khurana you used, are well-designed, validated features, big journals. Let's take one example of chest X-ray COVID-19. Nature Machine Intelligence did a review of all papers published on chest X-rays for COVID-19, thousands, and found barely any were of any use in terms of meeting usual clinician standards in what constitutes usable AI. And that is something that Dr. Jain alluded to, why he's skeptical. And let's come back to the logic. You can take RT-PCR positive, negative, chest X-ray positive, negative. If you take a test that's only 70% sensitive at RT-PCR, you'll have lots of people who are chest X-ray negative, RT-PCR positive. Then you do machine learning, and you start interpreting your cases that are RT-PCR positive, chest X-ray negative, and you go to the heart. And you never included any heart people in your sample sets. And you end up with interesting new features of deep learning that make it better than radiologists or clinicians. And that's exactly the wrong way to go. What you want are properly designed studies in which all types of samples, all types of things that would confuse, ILDs, tuberculosis, heart failures, effusions, everything is put together. Then you run the AIs. And I think what we are lacking today in the field, and I would love your response to that, Deva, is that unless we design these studies correctly from the clinical side, engineers sometimes tend to be overconfident on what things would find. And one particular reason I would say in radiomics, I keep hearing people talk about its microscopic feature being predicted radiology. A simple thinking of the dimensions of a voxel versus what you see on a histopath slide to tell you that's not what you're seeing. What you're seeing is a correlate to it on some other features on a radiological scan. It is not identical, and you need lots of testing before you can introduce into clinical practice. And that's why I think this session was so wonderful. Any of the panelists would please take up this.
You are so correct on that. For instance, we must first of all acknowledge the fact that a chest X-ray is not the way to diagnose COVID in the lung. That is primarily wrong. And we were aware of this from the beginning. because everybody with a normal chest X-ray showed up beautiful things on an HRCT, which is the correct way to look at this. So you're starting from a wrong point, obviously you're going to end up at a wrong point. It's completely stupid of us to even try this thing out. What we really need to do is look at chest X-rays and say, okay, I don't know which ones to put on top of the pile because a radiologist can only see that much. That is the only function of that chest X-ray. Everything else is eyewash. First of all, why should we waste a technician to do thousands of chest X-rays when we know it's a useless technique to detect that disease or to tell you about the severity of the disease or to triage that patient into hospitalization versus not hospitalization? And this is what we discussed in the interdisciplinary section yesterday, that we have to work together. We have to wake up together, we have to go to the beach together, we have to have breakfast together, and we have to have tea and coffee and everything together, and our spouses have to meet each other, and then these ideas come alive, which is really the way we have to go. The science is now so diverse that there's no question of not working together.
Since Anurag is there, let me ask him a question. Anurag? You know, we have been discussing about AI in imaging primarily so far. But I think there are many other fields where AI is required. And one of the fields is genomics and big data. I mean, today it is possible that you have, big data in genomics coming out and you can say, this is the SNP there. You may have a, increased chance or decreased chance. But to take it to the clinic where you can actually say by a whole exome or whole genome sequencing, whether this patient is likely to have a disease 10 years down the line or not. Have we reached that point yet or no? Or do you think that there is a case, there's a possibility in near future to do that?
The only place where we have reached AI in genomics is the equivalent to your segmentations and finding features for well understood things. So combing through a large exome for hundreds of known informative mutations is better done by computers compared to humans. And a little bit of AI is there even in assembling the genome. So far, so good. Just like there is AI in assembling the image coming out of the machine. When you come to common diseases with low odds ratios of individual findings and using thereby multiple combinations of multiple mutations in machine learning big data ways to give you effective predictions. No, we are not actually there for clinical practice. And half the time it would not change what you do anyway. And the last most important part, we don't even know how to address it for a young person. So for example, you take a young girl of say 6 years of age, you sequenced, you got an OR of maybe 5 for breast cancer. What exactly are you going to do? So I think we are a very, very far away from figuring out how to use genomics to start addressing things that occur 20 years down. Neither the science of it, nor the ethics of it, nor even the engineering.
Thank you, Yashdeep. You may take questions from other audience delegates.
Thank you very much for this wonderful session. My question is a very simple question. So whereas we develop the DL algorithms, we talk about what is called as unidirectional flow. That means that you give an input and you get an output. But what I hear, at least from my clinical colleagues, is that this bidirectional interaction is missing. So that means that, we would like the expert to also give an opinion or give some input to the model. At least it should go back and do this process. So do you see that as a big push for yourself to trust AI? Or do you see that as a bottleneck for saying that, AI should be an independent one, which should give independent opinion?
Obviously, you are absolutely correct that it has been a unidirectional kind of thing whenever we talk about AI so far. Although many of the clinicians are actively involved as collaborators with the people who are developing these algorithms. And definitely when we work with you and we get the desired answers, when we actually, what gives us confidence is that when we are analyzing a case or maybe a patient, we look at a lot of these other things, other than the patient's demographics, the clinical presentations, and then the images and other laboratory results to come to a conclusion. So if you collaborate with us, if you talk to us and you
give us that confidence that all these factors which you look for have been taken into consideration, then definitely we'll have more confidence, and we would be rather happy to use all these AI features.
So I think there has always been a gap between what a clinician wants and what a person with a certain AI he wants to give. So we need to explain first. So when we initially incorporated AI into endoscopy, so the initial endoscopy view resolution was low. There were very high false positivity rate. The machine used to flicker here, and you used to take a lot of time while doing a normal endoscopy. So over time, with feedback and over repeated meetings with different meetings, this software has been improved so that it can pick up better and it can have lesser false positivity. So obviously, it has to be guided. So we need to the AI expert need to understand what we need because be it endoscopy, be it ultrasound, everything is very different, and what we need to say specifically, and that has to be evaluated and given feedback. That's how it should work.
I think in interest of time, we have to close this session. Maybe Dr. Pramod, you sir, you want to add on this question? I think this is very.
No, I'm fine. Thank you. Yashdeep, we can close it. I'd like to just thank all the speakers and the organizers once again.
Yeah. Ma'am. So
yeah,
please, ma'am.
Okay. Thank you very much for all the wonderful sessions. I've never heard of them before, but I'm a pathologist. And my question is, you said your sensitivity is 90%. So what happens to the 10%? I appreciated Dr. Abhinav when he said a medical educationist would never agree to have the resident being taught AI, because where does the clinical skill come in? Dr. Soumya did say that his endoscope, it helped to pick up lesions which he otherwise would have missed. But what happens to the false negatives? And what happens if I am the patient and I fall in the 10%?
So we face this all the time. So if an ultrasound scan is being done by a novice, I know that I will pick up 33% of anomalies. And if it's being done by an expert, we will pick up 94% of anomalies in the mid-trimester anomaly scan. If I refuse to grow up and I don't want to become an expert, I will constantly miss 66%. What is AI helping me do? It's making me sure that I reach from 33% to 94% much faster. And that's the way to look at the statistic, that the lesser skilled person is not the 10% that is being missed by the expert, but they're actually missing a whole lot that should have been detected. So just because I'm trying to make somebody an expert, should I neglect AI and say, no, you deserve to have a bad destiny because I have to train my doctors? And that's not right.
No, but I think this is an excellent question. Let me also pitch in here that we can't and we should not and we do not make decisions based on one particular information. And I think there was something which Deva mentioned. You need synthesis of data coming out from different sources. And for example, Soumya mentioned in the example of a chronic pancreatitis, we have something, clinical phenotype, we have imaging features, we have etiology, we have many other things. So even when a pathologist tells us, correlate with clinical features, and madam, that's often the report we get. So we have to take into account all the information that we get before we make a decision. So surely one could fall in that 10% category of false negative, but there are other ways and means by which we will make an informed decision. Thanks.
That's true, sir. And we need to collate information from others also before we conclude or go for a diagnosis. And regarding this medical education also, so many times we find that rare diseases are not, the residents are not exposed to rare diseases. I would put a counterpoint against that. we can even generate images looking like disease and normals using GAN algorithms. I mean, I'm not sure it is already there, but it is already there for photographs. You can create a photograph synthesized entirely by AI. GAN algorithms can do that. So similarly, if we can create a case study, it's very difficult for someone to find the entire spectrum of diseases in any institute or any hospital. Whereas if GAN is matured in a way that it can generate all the spectrum of lesions, polyps in case of endoscopy, or in mammograms, it can create multiple microcalcifications, or any even in rare disease, it can even create a normal looking and an abnormal looking, all varieties of in that spectrum. So I mean, it has a positive thing in that it can help in medical education. I understand that people and residents should be exposed to normals as well, but I'm just saying that it can help in rare diseases to generate images.
I think it's a wonderful session. You have a views on both pros and cons. I think this discussion which is generated will be like igniting factor for future collaborations and work. Thank you so much for to all the speakers, and with permission of Dr. Pramod, I would like to close this session.
Thank you.
Thank you and have a nice day.